Hi, welcome back. We're going to continue our discussion on autoimmune disorders. We're now going to talk about systemic lupus erythematosus, or SLE. This is another chronic inflammatory autoimmune disease with a course that is variable with alternating exacerbations and remissions. It is a very complicated and unpredictable course of the disease. There are several factors involved with the development of SLE. There's a genetic component, and we know that there's an increased incidence in families that have kind of the diagnosis of SLE. Also, hormones play a role. The onset and worsening of SLE happens during hormonal changes, such as menses, the start of birth control pills, or some kind of hormones, as well as during pregnancy, before and after pregnancy. The environment also plays a role. UV light and chemical exposure and certain medications such as procainamide can lead to the development of SLE. It is a multi-system type of disease process, so it's affecting not only the skin, joints, but serous membranes and the pleura and pericardium, also the renal system, the hematologic system, and the neurological system. So the etiology is that these antibodies form and are attacking the cell nucleus and DNA. And these immune complexes are deposited then in the basement membranes of the capillaries in the kidneys and the heart, the skin, brain, and joints. And this will trigger an inflammatory process, and it will start damaging that tissue. The hallmark signs and symptoms of SLE are the butterfly rash over the cheeks and the bridge of the nose. There's also arthritis and pain in joints that develops, and kidney damage. You have glomerulonephritis developing. This can progress to end-stage renal disease. These patients oftentimes have an increased risk of infection because of impaired immune functioning, impaired phagocytosis, and also because of the use of immunosuppressants. So the way that we kind of deal with it is we diagnose the disease by looking for those antibodies in the blood. And once that's been diagnosed, we start collaborative care, and we're using NSAIDs to treat that pain and inflammatory process kind of occurring. Anti-malarial drugs are used because they help with fatigue, and they also help with the skin problems and the joint problems. Methotrexate is considered a steroid-sparing drug that they will use to immunosuppress. They may potentially use corticosteroids, but they're kind of limited because of their side effects again, and it's they try to really shorten the amount of time that somebody is on steroids. The immunosuppressive drugs, they are used for more organ involvement when there is more systems involved. And the goals with therapy for SLE are to control the pain, to provide good symptom management, and to decrease the amount of organ damage that is happening. So with early diagnosis and treatment, hopefully we can slow some of that down and slow some of the progression. All right, fibromyalgia is another syndrome that we're going to talk about, and it's actually not an autoimmune disorder. So why do we include it here if it's not an autoimmune disorder? That is because it resembles, the signs and symptoms of fibromyalgia resemble some of the other autoimmune disorders. So again, it's important to look at distinctions. And so that's why we really want to include it here for you to understand along with the other autoimmune disorders. So fibromyalgia is a pain syndrome of the musculoskeletal system. And what it does is cause widespread tender points in the body along with extreme fatigue. What is happening in the body is that you have these abnormal sensory processing occurring in the CNS, and what that does is cause this increased perception of pain for the patient. So their idea of pain changes, and they experience an amplification of pain. And they think that there's a genetic component as well as a trigger that can lead to fibromyalgia, trigger such as illness or trauma. And so that can be very similar to our other autoimmune disorders. This disorder is very commonly misdiagnosed. They will try to rule out other things before they can confirm a diagnosis. Women are mostly affected. 75 to 90% of those diagnosed with fibromyalgia are women. So there's a hormonal component to it. It is a very common cause of disability now in our population, and because of that is an active area of research. So the fluctuating widespread burning pain is your biggest symptom of fibromyalgia, and it kind of fluctuates. It gets better and it gets worse. The pain is hard to describe for the patients. It's hard for them to pinpoint if it's in the muscle, the joint, or if it's in the connective tissue. They also will experience this temporomandibular joint dysfunction, kind of accompanying the pain. And like I said, they have these tenderness points. On the diagram here, you can see where those tenderness points are. This is in addition to kind of that widespread burning pain that they have. They can also have cognitive effects such as difficulty concentrating or memory problems, or feelings of being overwhelmed with multiple tasks. And they can also experience migraine headaches. Other complications are stiffness, sleep issues, and paresthesias. They may have trouble with restless leg syndrome. And things can progress to difficulty swallowing and increased frequency of urination or urinary urgency. Women can also experience some difficult menstruation during that time. It's very cyclical, so one thing kind of leads into the next. As you can see on the diagram, it's muscle stiffness leads to pain, leads to muscle tension, causes daily stress, and it just keeps going around. So one thing kind of leads to the next with fibromyalgia. For diagnosis, it's difficult to diagnose. It's kind of one of those nebulous types of syndromes. They do look at a muscle biopsy. They check for fiber atrophy to show that the muscles are affected. They do have criteria now for diagnosis, and they're looking at if 2 criteria are met, that is if they have the pain in 11 of those 18 tender points on palpation, and also if they have a history of widespread pain for at least 3 months. So that's what they look at for criteria now. They will also look at the other signs and symptoms that are kind of correlating with the syndrome: fatigue, cognitive symptoms, somatic symptoms, which are kind of like pain in the deep tissues and skin. That will help them establish the diagnosis better. Fibromyalgia care is symptomatic, so we're treating those symptoms of pain. We're promoting rest, and they will use drug therapy for the chronic pain that we often have heard about, the pregabalin, the Lyrica, and they also start to use antidepressants, the TCAs, the SSRIs. That helps with the pain as well. They will give muscle relaxants to these patients. They also may treat them with antidepressants because of the amount of depression the patient is experiencing. Supportive care includes things like massage, low-impact exercises to prevent muscle atrophy, Stretching can help with relieving tension and spasms in the muscles. So those will all be encouraged for your patients. Okay, and our last topic for our autoimmune discussion here is chronic fatigue syndrome, or CFS. This is another one where it's not technically classified as an autoimmune disorder, but the risks are similar to other autoimmune diseases. The features are similar, and especially to fibromyalgia, so we like to include it here. They have a new name that they use for chronic fatigue syndrome. It's systemic exertion intolerance disease, or SEID. It's where you have immune dysfunction that is characterized by this complete, absolute fatigue. And they say fatigue for greater than 6 months. It's not well understood. That's what makes it a more complicated type of syndrome. And so we just try and treat it similarly to fibromyalgia and kind of follow the same principles with chronic fatigue syndrome. For diagnosis with this syndrome, you have to have 3 of these symptoms. You have to have profound fatigue for, again, greater than 6 months. Post-exertional malaise, which is that complete exhaustion. And this could be from very minor amounts of physical exertion or mental exertion. And then also you have to have this unrefreshing sleep. So sleeping but not feeling rested afterwards. They must also have at least one of these things with cognitive impairment, either cognitive or worsening of symptoms upon standing. The cognitive impairment might feel like some kind of brain fog that they're in, and the worsening of symptoms when they're standing is the other thing that can happen as well. So they must have at least one of these types of symptoms. Again, many clinical features are similar to fibromyalgia, and that is why we include it here. And so it's hard because they many times are misdiagnosed, and it's a very real syndrome for the patient, but getting the medical community to recognize the diagnosis and treatment can be a challenge in this one. Okay, and that wraps up our discussion on autoimmune disorders. Let me know if there's any questions about any of the specific types. I will be including some case studies for you and some other activities for you to work on.